I wanted to welcome everyone to our webinar today. My name is Winnie Sivalak, and I'm the Senior Marketing Manager at Dreger and will be moderating today. Well, it is my pleasure to introduce today's speaker, Dr. Mitchel Goldstein. Dr. Goldstein attended the University of Miami's honor program in medical education and completed a pediatric residency at the University of California, Los Angeles, and a neonatal perinatal medicine fellowship at the University of California in Irvine. Dr. Goldstein is board certified in pediatrics and neonatal and perinatal medicine. He is a professor of pediatrics, Loma Linda University Children's Hospital, and medical director of neonatal ECMO. Dr. Goldstein is the editor-in-chief of Neonatology Today, the chairman of Physicians Against Drug Shortages, and medical director of National Coalition for Infant Health. He is the chair of the AAP Multidisciplinary Action Group Section Forum Management Committee and past president of the National Perinatal Association. But what's most important is the trait of his tireless devotion to patient access issues. He has been a vocal advocate for right-sizing technology. When hospitals nationwide had issues purchasing medical devices vital to patient care, Dr. Goldstein took time out to write to both senators and members of Congress. He testified in front of the United States Senate Subcommittee of Judiciary regarding practices of GPOs and the restrictions of access to vital medical devices and pharmaceuticals. Dr. Goldstein's vigilance in modifying these practices and improving patient access made the front pages of the New York Times and was featured on 60 Minutes. Dr. Goldstein advocated improving the physician-industry relationship as a crucial asset in providing exceptional care. He supports transparency, dialogue, and better engagement with industry to ensure the most advanced pharmaceuticals and medical devices are developed and available for at-risk pediatric patients. Welcome our speaker today, Dr. Mitchel Goldstein.
This is about concepts in neonatal ventilation. I'm going to start by disclosing that this talk has been sponsored by Dreger. I will also talk to you about various objectives that we're going to look at here. First is an introduction to ventilation of neonates. Next, what we're going to do is talk a little bit about pulmonary function and mechanics. And then the real aim here is to talk about SIMV and assist control, the volume guarantee modes of this type of ventilation, plus or minus pressure support with SIMV, and to give you an understanding not only of these modes, but when might be appropriate to use one versus another. So with that, let's start off. And I want to talk about neonatal ventilation. It's a relatively recent innovation. When we look back historically, going back even 50 years ago, neonatal ventilation was really haphazard at best. In 1963, the President of the United States, President Kennedy, had a son who was a late preterm baby. He had RDS. He was a big baby. But rather than be able to put him on a little bit of CPAP or, perhaps intubate him and give him surfactant, we had nothing. There were no ventilators at that time that were capable of accommodating what his needs were. Segue forward, Jimmy Schultz, a respiratory therapist, designed the first continuous flow limited, pressure limited, time cycled ventilator. At this time, these ventilations were the standard of care, and we were lucky to have them. It was something that represented an innovation well beyond the ventilators, which were largely adult accommodated, volume, old style ventilators without continuous flow that were really difficult, not only for the adult practitioners to use, but for us as well. nobody really knew what they were doing. I mean, long inspiratory times, short inspiratory times, low peeps, high peeps, continuous flow, non-continuous flow. There were huge dead space issues. And what about volume? Well, nobody really knew. I think as we went forward in time, things got better. The 1980s brought more standardization. Scalars and loop demonstrations of ventilation came out of research and began to be implemented in continuous practice. But infant breathing, the idea that a baby could spontaneously breathe, was problematic and disrupted ventilation. At that time, and we're talking about early to mid 80s, sedation and paralysis were necessary to ventilate the baby. We talked about doing this not so much from a standpoint of what was best, but what was necessary given the technology of the days. Pneumothorax, bronchopulmonary dysplasia, and other forms of chronic lung injury abound. We learned about the complications of what happened when we did things wrong. And we learned, unfortunately, very well, because there were so many babies who were affected. Towards the end of the 80s, surfactant was finally available. But with most NICUs not monitoring tidal volumes, certain morbidities became even more common. It's not that we didn't have pneumothorax, we actually had them even more quickly. As babies' compliance improved, we were not aggressively weaning on ventilation to accommodate the improvement in lung capacity. So when we look at it now, inadvertent hyperventilation remains a common problem with pressure-limited ventilation, especially early in the patient's clinical course where this lung compliance can change. So if you're talking about a preemie who has respiratory distress syndrome, who has been intubated for this particular worsening lung disease, if you put this baby on a pressure mode ventilator and the volumes change, who's watching the shop? When you think about the lung fluid, surfactant administration, and optimization of lung volume, this is something that should occur with someone right at the bedside. But what if that person has 2 or 3 other babies to watch? What if there's nobody at the bedside when this improvement occurs dramatically? When you see these improvements in FRC, along with improvement in lung compliance, tidal volumes literally run away. You can see improvements in tidal volumes on pressure-limited ventilation that are 2 or 3-fold in situations where the baby is severely affected by RDS. It is this excessive tidal volume, not pressure, that is responsible for most lung injury. So this exceedingly high inspiratory pressures may have been thought to be a chief contributing factor to lung injury in the NICU historically. But as we have come to see, it is the fact that this volume is transmitted with this pressure that causes the problem. And although we've used this modality for more than 30 years, the context that we need to regulate our volumes better has just been something that has come to bear. People are now just finally realizing it. One of the advantages is that with respect to this pressure-limited ventilation, why people prefer it is that they could control the volumes. But again, if you could control the volumes and have the volumes dictate what your pressure is, certainly that would be an easier way to do things. And so more recently, although honestly it's been available for a decade, volume rather than pressure is a critical determinant of the ventilator-induced lung injury, and it is now finally what people have started to turn to in terms of better regulating the ventilation that babies get. And I'm going to go now and kind of put the cart before the horse. Rather than talking about tidal volume, I'm going to talk about the one thing that really matters. And I'm going to preface this by saying, if you learned only one thing in this whole lecture, let's talk about C20C diet or C20C. What I'd like you to know is that there's one number, and that number is 1. And that is the most important part of this lecture. There will be some fluctuation in this number, but if this number is less than 1, there may be overdistension, and you may be in a position where you're giving too much volume to that baby. If it's more than 1, generally you're okay. So what is a C20C? C20C is the last 20% of the inspiratory compliance limb over the dynamic compliance. And I'm going to show you an example of that graphically, but I think now at this point we can talk about tidal volume. So tidal volume, and when you think about tidal volume, everybody has a preference. You know, is it 3 to 5? Is it 4 to 6? Is it 6 to 8? Or maybe for the bigger babies, it's 8 to 10. But really what it comes down to is minute ventilation. Normal minute ventilation is between 250 and 350 milliliters per kilogram minute. And this translates to what you see on the ventilator as 0.25 to 0.35 liters per kilogram minute. When you think about normal newborns, they tend to breathe between 40 to 60 times a minute. So when you figure this out, using the fact that they breathe that fast and you need to target that minute ventilation, well, basically it's 4 to 6 milliliters per kilogram breath. That's physiologic. And what you're trying to do is achieve these tidal volumes to match normal minute ventilation. And again, there may be diffusion issues, there may be other issues that you have to think about, but this represents a primary target. So as opposed to looking at it from a standpoint of which number is best, from a standpoint just the tidal volume, not considering minute ventilation, it's helpful to look at this as well. Babies who breathe fast can get by with smaller tidal volumes if they have good compliance. Babies who breathe slower may need higher volumes. But higher tidal volumes are not normally necessary. So again, let's go back to the idea of ventilator-induced lung injury. Would you want a smaller preemie to have a tidal volume of 8 to 10? Well, smaller preemies don't breathe slower typically than 40 breaths per minute unless they're having apnea or unless there are other issues going on. So you want to think about targeting that normal range. And now let's go back to what happens with C20C. Because when you look at your normal loop, and you can see on the bottom airway pressure, and on the side volume, you can see a normal hysteresis. And the normal hysteresis is this basic blob that kind of looks like a football, and that's indicated on the inspiratory limb by your red line. So you see how that line is almost symmetric in inspiration and also in expiration. It really has a nice quality to it because, again, you could see this widening up of this loop, which is something that you see with good compliance. Now, when you start to see issues is when there is a problem with this inspiratory limb. And what tends to happen is that you see this limb buckling in on itself somewhat. And it tends to match the line of identity, which is the line of dynamic compliance, which is reflected in here as this dotted line. So as this inspiratory compliance limb tends to approximate to that limb, what happens is that your C20C starts to approach 1. What does that mean? What it means is that the last 20% of this loop as compared to this whole dynamic compliance here is basically the same. You're starting to get to the point where you're going to be in trouble. It is when you see it go over here to the light blue and you could see how it buckles up at an extraordinary quick pace and then gets up to this point where it literally looks like a bird's beak. And yes, we sometimes refer to this as beaking in classic terminology. But it's when it gets to that point that your C20C is less than 1, and you may have overinflation. And quite fortunately, this is a measure that's available on the ventilator, and it's something that's important to look at. Now, whether you've targeted a tidal volume of 4 or 6 or any other tidal volume, it's very important to look at this particular number, because if you find yourself in a position where it's significantly less than 1, you may want to reevaluate your volume targets. And this, again, is something that's going to be very important as we talk more about whether the choice is going to be volume in an assist control or an SIMV mode. What makes this all possible is this device here. And what you see here is something that some people will call a flow anemometer, some people will call a pneumotachograph, but it is simply that, a flow sensor. And what you'll notice about it is that the action point, which is this point here, that is connected to this cable, is a very small chamber. In the past, we would see some of these pneumotachograph or flow sensors in the range of 3 to 5 mLs, and this would be very problematic. The fact that this particular flow sensor is very well engineered and takes very little dead space makes it possible to do this volume targeted ventilation. So this is an essential part of the setup. Looking at traditional flow scalers, one of the things that I want to emphasize in all types of ventilation is looking at what happens in expiration. So again, when you're doing SIMV or whether you're doing assist control mode ventilation, if you do not see complete emptying in your expiratory flow, this can lead to situations where you will have air trapping and at times increase the amount of inadvertent overdistension that you have, resulting in an inability to ventilate successfully. So what you're looking at here in a flow scaler is to make sure that the expiratory flow, as demonstrated here, actually reaches back to that baseline here before the initiation of the next breath. And again, a very important point, whether you're considering pressure limited or whether you're considering volume guarantee mode ventilation. Let's look at it a different way. And here again, very important to see what happens with the flow volume loops. And on top, you see inspiration. And on the bottom, you see expiration. With these particular loops, although the interpretation of what happens in inspiration and expiration can be very technical, the most important part is to make sure that when you're looking at this, you see this point you don't see rather this point of a gap. This gap may represent air trapping, and this scooped out appearance that you see is indicative of the fact that it doesn't quite get to where you want it to be. So when you see these two instances, first on the scaler, where it doesn't get back to the baseline, and second, where you see on the flow volume loops, this scooped out appearance in expiration, where you don't quite touch or where you don't quite connect to your inspiration, that also can indicate trouble with emptying and can result in significant gas trapping and result in issues with volume delivery. So let me now give you an overview of the Draeger ventilator. And this is typical of the screens, and this is, I think, a little bit older than some of the more newer updated screens that we see. But what you'll typically see is you'll have your pressure indicated here on the top line. On the line underneath, you'll have your flow. And again, depending on which screen you select, you may have various representations of your loops. I would encourage that you look at your waveforms and your loops in concert, because it's very helpful to know what's going on. And in this case, the loops look pretty good. And you can see how on your pressure volume and your flow volume loops that you really have a lot of the good features that I've described. With your flow volume, you can see how in expiration, and I'm trying to get my pointer to come back to me, but you can see how it actually comes and touches the inspiration beginning. So you don't see any air trapping here. You can see on the flow considerations that following the breath, it really does get back to zero before the initiation of the next breath. So this is something that you like to see. Now, the other thing that I'll tell you, on the Draeger screens, you'll have an identification of the mode. So this is PC, pressure control, assist control type ventilation. You will not typically see a PS here because pressure support is not supported in this mode. But where you're doing volume guarantee, you'll see that typically appear here. You will have other parameters that you'll be able to see and follow. Your tidal volume, whether it's set or whether it's measured depending on the mode. Your PIP, your tidal volume per kilogram, provided you set the kilogram weight, respiratory rate, and FiO2. Your adjustment settings are down here as well. I find that sometimes this is a little bit difficult to use and to kind of get the hang of, but there is actually a simulator on the Draeger website, and I would encourage that you use that simulator because it can really help you get used to the idea of setting and working with these controls. I've used it and I have to endorse it wholeheartedly. So let's look and see what happens with SIMV. And this is SIMV, and SIMV with pressure support dialed in. In this case, the pressure support is at a very low level, and it's hard to visualize from a standpoint of the pressure here. But you have your option of setting this as much as 5 or 10 or 15 higher. And typically, these breaths are more abbreviated breaths than your actual SIMV breaths and show up as small little spikes in between these breaths here. What happens typically is that this is a mode that can be used for weaning, and we'll see maybe a little bit of a better example of that later on. I want to indicate here that the SIMV rate here is the maximum amount that the ventilator will support. So unlike assist control, the SIMV will support to the rate that you set. If you set an SIMV rate of 20, the pressure will be supported for those 20 breaths and no more. Any additional breaths will have the pressure support added on to the ventilation. Let's compare that now to assist control, where the ventilation rate that you set is the minimal or nominal number that you will have synchronized. Even if the baby becomes apneic, that number will be given, but if the baby's respiratory rate exceeds a certain point, you may be uncomfortable. So if a baby is breathing 40 to 60 on a pressure mode, that may be great, but as the tidal volumes start to take off, you may find out now that you're giving minute ventilation in excess of 350 mLs per kilogram minute. And many times you'll see 600 or 700 numbers. And so assist control requires even more attention than does SIMV, because not only is there the potential for there to be improvement in compliance, there's also the potential for the baby to become tachypnic, say in the face of a metabolic or lactic acidosis, trying to normalize the pH. So in this context, you have to really watch your minute ventilation. Now, here's another example of pressure support. Here, the baby is getting SIMV, and unlike what I was talking about previously with assist control, you can see that as the baby's breath rate increases in SIMV, you have the pressure breaths, and then you have these smaller breaths, which are designed to help overcome resistance and help the baby breathe in between these larger SIMV breaths. Now, when we look at this, again, it does not necessarily support every breath. But again, in the interest of not having runaway minute ventilation, this mode may, in the context of pressure limitation, be a safer place to be. Let's look now at what happens with volume guarantee. And with volume guarantee, what you'll notice here is that the size of the pressure deflections is less than the previous slides. I mean, in some cases, dramatically less. And that does not reflect a problem with the mode, but it reflects that the mode is adapting as the baby's compliance improves. So as the baby's compliance improves, what you see is a reduction in this PIP level that oftentimes comes very unexpectedly. People don't understand at first when they see these numbers that in fact these numbers are real and actually reflect the fact that the volume delivery is occurring. When you add in pressure support, and pressure support is not registering here, but again, you will see these minute pressure spikes. I will tell you that because of the fact that your volume delivery is so efficacious, it's very important when you're doing SIMV in volume guarantee with pressure support to make sure that these pressure support supplements are not in excess of the pressure that you're actually giving with your volume guarantee breaths. So in this mode, typically a pressure support of 5 is the most that I will give. Slope is something that I'll just mention in passing. There are various theories as to what is the appropriate slope for a baby who's preterm. Some places will use a 0.1. I believe the manual recommends a 0.05, but it is the rate of attack of the inspiratory breath. And again, as opposed to a square wave, it controls how that breath comes in or enters the lungs. This is assist control and volume guarantee. And what you'll notice here, again, is something that looks very similar to the preceding slide. But in this context, every breath receives the support. So there are no pressure support breaths because of the fact that you do get a volume delivery with every breath. Now, although you can set limitations on your PIP in terms of what's given on a maximum side, the rate still can get too rapid and you can see situations where your flow does not return to zero. Your minute ventilation can still take off because of the fact that if you're ventilating, say, with 5, let's say 5 mLs per kilo per breath, you can see how at 80, that would be 400, at 90, it would be even higher. And so you can get into situations where you might want to further reduce the amount of volume that you're giving. Now, look here at what's happening. And again, it's not evident from the scalars, but if you look at the loop here, this loop doesn't return to zero. So this baby may be going a little bit fast for that mode of ventilation. Because of the fact that you don't have a scalloping here, this may also reflect tube leak. Although, again, when you look here, your tube leak is 0. So be very mindful of what can happen with any of these modes and be able to distinguish these and be able to understand where you are. I think, again, as we started out, you really want to start by considering where you are in terms of your minute ventilation. And if you see that your minute ventilation is getting to be too high under your PCAC mode, it may make sense to go to an SIMV with volume guarantee and pressure support to see where you are. Now, what is the value of pressure support beyond these types of ventilation? And one of the more useful things that I can say about it is that even at very low levels, say 5 centimeters above your baseline PEEP, it can really reduce the resistance necessary to give adequate ventilation. So why not just use pressure support? Well, some people have, and pressure support takes the place of endotracheal tube CPAP that some people have used, albeit unsuccessfully, at an attempt to prove that a baby can extubate successfully. From my perspective, oftentimes you can use it as a measure of a baby's drive. So if you have a baby that you've transitioned from PCAC with volume guarantee to a mode which is basically SIMV volume guarantee, and you're trying to see how much contribution the baby is able to give, what you can do is make, at times, very dramatic decreases in your SIMV rate and see what happens to pressure support. If your ratio of pressure support breaths increases and your baby is able to keep up, oftentimes what that will mean is that the baby has increased readiness, at least neurologically, for extubation. From a standpoint of being able to achieve that minute ventilation, oftentimes if you take your SIMV rate down and you see an increase of your pressure support breaths to a tolerable rate, say from 40 to 60 to 70, but minute ventilation is sustained, that may indicate that your baby is ready for extubation. So what I'm going to do now is I'm going to go to the next slide, and I'm going to talk a little bit about various strategies and how you might want to approach these. I think at this point, I'd like to kind of open it up for discussion as well, because as I do this, I want you to call me out on certain things, and I want you to ask me questions and see what my thought might be in terms of how we move forward. And again, I'd love to hear your thoughts in terms of what we might do. So we'll start first with surfactant delivery. And surfactant delivery is something that we do for babies with decreased compliance and what is very stiff lungs. When you look at that, remember that we're talking about a scenario where there's a very quick change in compliance oftentimes with a pressure mode ventilation giving excessive volume if not watched very carefully. And so in this scenario, I'd like to use a mode where I have assist control but volume guarantee as opposed to pressure, because again, I can control where I am. As long as I know that this baby is going to be breathing in a range that results in a return of the flow to baseline, I can set my tidal volumes and I can watch very carefully. I can look for the possibility of overdistension. If my lungs are particularly stiff, I can set an upper limit for pressure that I won't necessarily tolerate. But this scenario will give me a very good way of getting this baby through this process without really causing a lot of ventilator-induced lung injury or VLI. It does offer the ability to auto-wean, and for me represents what may be the safest way to move forward. Extubation. When I'm going to extubate, I like to look at what happens if I'm in assist control volume guarantee when I come down on the tidal volume delivery. At times, it's hard to gauge because of the fact that with this mode, the PIP pressure generations can be so low as to be difficult to interpret. And for those babies, sometimes what I'll do is I'll go from that mode to an SIMV volume guarantee with pressure support, with the understanding that an increase in pressure support breaths as I wean SIMV with minute ventilation still keeping within normal range may be an indication that that baby is ready for extubation. So you can actually use these particular modes to guide you in terms of extubation readiness. Where does this go wrong? Well, I mean, if I turn the SIMV down and there's no increase in pressure supported breaths, if the baby is apneic or the baby is desatting. This may indicate that the baby is not ready neurologically. I may have to increase methylxanthine, like caffeine delivery, or I may have to look differently, and I may have to approach it from a standpoint of, gee, this baby may not be ready for me to come off. And then there are my non-invasive modes, high flow. And high flow is available on the Draeger ventilator, so you don't necessarily have to change your apparatus at the bedside. CPAP. CPAP has been proven and has been shown again and again to be probably the best way of coming off ventilation for these small babies. And although nasal intermittent ventilation may have its role, I think at this point, the jury is still out as to whether this results in a considerable improvement over CPAP in terms of its ability to deliver sustained FRC pressures and whether the ventilator rate is adequate and necessary to get the babies off ventilation. Let me go on to my last slide. And basically, I just want to point out that there are other things that are important to consider. And that is that the leak adaptation and leak compensation technologies that are present in the Draeger ventilator offer a superior solution to issues of right size tubing. Although it's important to keep the baby, quote unquote, midline with respect to the endotracheal tube. And I do this by lining up the baby's chin with the baby's umbilicus. Yes, you can have the baby to the left. Yes, you can have the baby to the right. But you don't want to have a situation where your head is off to the right or your head is off to the left. Especially with small babies, this causes the endotracheal tube to go into the lining of the trachea and can result in unattended leak or problems with ventilation. But even in this context, the Draeger mechanism is able to compensate and provide superior solutions. Volume guarantee can be used for weaning and promotes spontaneous breathing and automatically adapts to the patient's needs. And remember the use of pressure support, especially when trialing an extubation algorithm. Where you have integrated non-invasive ventilation and high flow, it represents a natural continuation of your ventilation algorithm. And without having to interrupt your circuit or to go, for that matter, to a different ventilator, it's definitely a time saver.